focus review. So here we are in Barcarolas, and see this interactive review. Foundations. If you click that on, you probably already know this, but I'm making sure you do. It will take you to some test questions for every chapter. That's just kind of a good way to make sure you had the overview. And before we get started, I just thought I'd do a couple of questions with y'all, because some of this stuff you may already know. And doing a couple of these questions may help you kind of practice your test taking skills. Okay? So we're just going to do them kind of cold turkey. And they are pertinent. They are pertinent to the unit information that we'll be going over with you guys, to your syllabus. So you're carrying, all right, so and for Unit 1 is mainly an overview of mental health and mental illness, an overview of how you treat it. That's what modalities of therapeutic modalities. That just means what do we do about it? And we broke that down into drugs and then types of therapy. And then it's talking about, well, what's the nurse's role in all of this? And then community resource and communication. So that therapeutic communication you're going to use on Unit 2 and Unit 3. The meds you're going to use again on Unit 2 and Unit 3. The types of therapy, like group therapy, hospitalization, partial hospital, they're going to come up again too. Okay, so if you get Unit 1 a good foundation, you will see that a lot again in Unit 2 and Unit 3. Okay? So you're caring for Alyssa, and she's a 28-year-old patient who has a diagnosis of bipolar disorder. She was admitted in a manic state, and we're doing this. You may not even know what all this means, but we're going to go over some more problem solving on how to answer the question. According to Maslow's hierarchy, remember Maslow and hierarchy of needs theory, which of the following symptoms needs to be the first priority? So it's a priority question. You need to do it all, but what do you need to do first for Alyssa? Which of the symptoms needs to be addressed first for Alyssa? So she's manic, so she's got this rapid pressured speech. She's just talking 90 miles an hour, and it's very intense, and she's talking to you like that. That's one of her symptoms. Grandiose thoughts. You know, I am so important. They need me at the college. I have to be there every day. I'm the most important teacher there is. I mean, if I'm not there, they can't run the school. So she's doing all this. She's manic. She's grandiose. She hadn't slept. I hadn't slept in 3 days. I've been getting ready for class. I've been awake for 3 days. But it's okay, because I got a lot going on. I don't need to sleep. And she's hyperactive. I'm hyperactive. I'm just manic. I'm doing all this stuff. We haven't even gone over anxiety. We haven't even reviewed Maslow. We hadn't talked about these symptoms. But what do you think needs to be addressed with me first? Sleep. Right. Yay. So sleep would need to be first. Why is that? Based on Maslow's belief. It's a priority. It's a need at the base of that pyramid. You're not going to have a lot of success handling my other symptoms until you figure out some way to get me to get some sleep on board. Okay, so anyhow, just a good little question, an overview on how we study. So let's skip this one. It's not important for this unit. Okay, so let's look at this one before we go into Unit 1. You and Jack are two nurses working on the mental health or psychiatric unit, and Jack mentions to you that the biological model of mental health, and we'll go over that the biological model from mental health is the one he embraces and states, it's the only one I really believe in. So this is a belief system on what you think causes, is a cause of mental health problems. Jack believes it's this one theory on what causes mental illness. Which of the following statements is true regarding believing in only one model, believing in that one biological model? Again, not pressuring you. We haven't gone over this content at all. We're just doing a little practice in how you take a test. The biological model is the oldest and most reliable model for explaining mental illness. Maybe. The biological model doesn't explain every symptom. Maybe. The biological model is the most popular theory among leading psychiatrists. Therefore, the one that we should embrace is popular, so we should go with it. Or is it in believing in only the biological model, other influences on mental health, including culture and environment, social and spiritual influences, are not taken into account? D. Even if y'all have no clue what we're talking about, you can kind of see. Because intuitively, you probably know that if somebody has a mental illness, did one thing cause it? No. It's usually what all goes into mental illness, could cause mental illness. Heredity. There is a genetic factor. What else? Environment. Chemical. Things that are being taken in. So there's a lot of different things that go into mental illness. So I show y'all these just to kind of get you in that mental health mode before we start to go over all this content. And that was correct. Okay, and again, don't freak out. We hadn't talked about Sullivan, we hadn't talked about Freud. But I want you to think about what you already know about mental illness. Sullivan's term, security operations, and Freud's term, defense mechanisms, we know what vaguely know what defense mechanisms are. Both reflect actions that help us to increase our self-esteem, reduce anxiety, increase self-awareness, or reduce cognitive distortions. What do our defense mechanisms help us do? Help us reduce anxiety. When you're in a real anxious situation and you're real upset, what do we start to do? Our defense mechanisms start to kick in. So that's just on a intuitive, everyday, day-to-day knowledge of what we have about mental health. Okay, so just a couple of questions to get us thinking. Now, and a reminder to use those questions in your textbook. If you've read some stuff from today and you want to see if you covered it all, do that interactive review for that chapter and answer a few questions. ATI experts recommend that you're answering at least 25 questions a day. So every day, whatever you're doing to study with me, try to answer 25 questions a day. That does a couple of things. What does it do? What does answering some NCLEX style questions help you do?
The type of question.
It helps you practice. And the type of question, it helps you with the content, and it helps you for that overall goal of passing NCLEX. Okay, so every day you need to be answering some questions on the content you study to make sure that you're on the right track. Okay, so let's get into the content. This is like at the very beginning of the book, page 3. And your textbook shows the continuum of mental health and mental illness. I need my table. And if you look on page 3, there's some attributes of mental health. And on page 2 is the actual definition for mental illness. Okay, so page 2 and page 3 are where we're starting from on this. So if you're having a really bad day and you're anxious over a test and you didn't sleep the past week because your final exam is coming up, a lot of anxiety, and all. Do you have mental illness?
No.
Mental illness and mental wellness are like so many things are on a continuum, okay? And so what we will be talking about is understanding when we go from being mentally healthy to mentally ill. one of the key terms that you need to know and understand is resiliency. What's resiliency? That's actually your ability to bounce back. And that's one of the key things that we need to have to stay mentally healthy, because stuff happens in life and you have to cope with it, and then you have to bounce back to your normally functioning, highest functioning level. That's one of the things when you're assessing your client in mental health is how resilient are they. So you had all these things happen. Talk to me about what you're doing now that it's happened. Well, it was really bad for about a year or so, but I went to counseling and now I'm back working. I was able to move out on my own, and I'm still having problems, but I've done all that. Does that give you an idea that as a nurse that they're resilient? Yeah. On the other hand, if you ask them, well, talk to me about how you're doing since all this happened. Well, I just haven't been able to get my life on track since then. I ended up getting divorced. I lost my job, and I'm not any better yet. I don't think I'm gonna be able to go back to work. I don't see things getting better. Is that resilient? No. So mental health is a state of emotional, psychological, and social wellness. You have satisfying relationships. Everything's not a conflict. Every relationship you have doesn't end up in a train wreck for the whole world to see. You are able to behave appropriately, and you cope. You look at yourself in a positive manner. And when you look at yourself in a positive manner, that's when you talk to the patient and you say, well, what do you think about yourself? How do you feel like you're doing? Well, if that patient tells you, well, I've had some issues and I have some problems, but overall I know my family needs me, and I recognize I have some worth. I feel okay about myself. That's positive self-concept. We're not saying you have to say, I'm the smartest, I'm the best, I am super. It doesn't have to be that. Just, you want your patient to know that they have some positive worth. And emotional stability. They're not, every time something happens, they're not labile. That's a key word. Emotional lability. They're hot one minute and cold the next. And you know who I'm talking about. Oh, that's the other thing. Before we start this, don't diagnose yourself for the next 3 minutes. Because you probably want to do it more in here than you do in adult health. You know how you have like AFib and everything when you're in here, you're going to do the same thing. So we want to look at this not as a time to diagnose ourselves, but maybe just some time for growth. But you want to be emotionally stable. And that's a sign of mental health. I can't be so furious one minute that my blood pressure is up and everything, and then the next time, oh, I'm sorry. No, you want some stability in your emotional. And you're going to be assessing that as a nurse and your patient. How are they acting? How do they cope if they didn't get the right meal? What's their emotional stability like? Another key part and a real important part of mental health is spirituality. And spirituality is very personal. And we're not saying here, do you go to church every week? That's not how you would assess that as the nurse. You're assessing this in their belief in something, a higher power, whatever personally that is for them. That's the place with us that spiritually, this is how we deal with our relationships, our values, those big questions of why am I here and all. And it does play a huge role in mental health and mental illness, that people feel like they have some sense of purpose and they have resources that they can depend on outside of just other human beings. So we said earlier when we did that little one practice question that one thing is not usually the cause of mental illness, because you can look at a person, and we all know them, that's probably had something very traumatic happen in their life, that you may think would cause you mental illness if that happened to you, and then that person ended up being fine. It just depends. It just depends. But biologic makeup, there are genetics involved, and we'll talk about that a little bit more. Sense of harmony in their life, vitality. See, a lot of that is spiritual. Their sense of meaning, their sense of purpose. They have to have some of those things. They're able to communicate. They're able to help others. Mentally healthy people are able to reach out and help others. They're able to have an intimate relationship. They're able to be intimate with people. They're able to balance separateness and connection. That one's really important. I understand that you're my students, and I have a connection with you. It's a student to faculty relationship, and I value that, and I know where my boundaries are. If you're not mentally healthy, you have problems with those separations, and they'd be like, hey, are you doing anything for lunch? Want to go shopping? After class. That's where we're talking about problems with separateness and connectedness, okay? When you're mentally healthy, you kind of understand where this relation starts and this one stops, relationship. Sense of community. You understand you belong to a bigger community. You're not just putting yourself on an island. Mental health depends on access to adequate resources. And we'll have to talk about that in the country and the problems that we have there. Intolerance of violence. Generally, mentally healthy people do not like to see violent things happening to animals, other people, and they support diversity. I understand as a mentally healthy person that everybody's not like me, and I support that, and I understand that you're going to be different from me. Here it is on that continuum. And now, when you start to go down the continuum and into the mental illness, I'm sorry. You're talking about what moves you down that continuum is how much it impacts your ability to function. Okay, the further down the continuum, the more this mental illness is impacting me. Have I just got a diagnosis of depression and I'm able to see a counselor and maybe take an SSRI, work, function, have a family, kids, and I'm fine? I'm just kind of a little over that triangle. But if I have a diagnosis of schizophrenia and I have to be in a day program for people to help me, and I'm on several high-powered antipsychotic medications, and it's real difficult for me to even take care of myself, then I'm way down the spectrum, okay? But it's all in there. And the goal is to make sure that people are functioning at their highest capacity, okay? That's a big concept with mental health. Intervention-wise, whether it be restraints, whether it be antidepressant medications or therapy, or whether or not you're in the hospital or you're at home, the goal is always the least restrictive. Big term, least restrictive. If I'm going to put you in restraints because you're hurting yourself, I'm not going straight to the 4-point leather restraints in a room in seclusion. I'm going to try to maybe give you some medicine first. Least restrictive. See if that works. If that doesn't work, then I might put you in some soft mitts. That least restrictive. If you've come in and we've done a court commit on you, we're not going to keep you for 6 months at Whitfield right off the bat. We want to do least restrictive. Can we get you in the hospital? Can we get you leveled out? Can we get you to a program where you can stay like in a group home? Okay, so you got that concept of least restrictive. And your outcome is at your highest functioning level possible. Okay. We don't want to just say, well, she's schizophrenic, and we just do what we can. No. We want to say she has a diagnosis of schizophrenia, and our goal is to get her as functioning at the highest level we can. And that's what we're constantly striving for in the treatment. Okay? So keep those two concepts in Mental illness, clinically significant behavior or psychological syndrome marked by distress, disability, or risk of suffering disability or loss of freedom. Mental disorder or conditions marked by alterations in thinking, mood, behavior that cause distress, impair ability to function. And always remember, wherever you go work in the hospital or wherever you work as a nurse, you will do mental health. I don't want to be a mental health nurse. It's too late. You're already in level 3. You're going to be a mental health nurse. You might not work in a mental health unit, but you will be caring for clients who have mental illness. And you're just going to be caring for humans in general, so these skill sets will help you wherever you're at. And always remember, you know, one time we had a client, med-surg floor, like 3.5 weeks on a med-surg floor. And y'all know from being in the hospital, that's a long time. And everything kept going wrong. Every time he got ready to discharge, something else happened. And finally somebody said, well, have we done a mental health eval? And somebody kind of laughed, you know, like they're joking, you know, and we're like, and the person was like, I'm not joking, I think we need a mental health evaluation. Because physically we fixed everything we can fix. There's just something else going on with this client. And when we get to personality disorders, that will come back and revisit that thought process. And what we were chasing our tail with personality disorder. So just remember, you don't have total health unless you have mental health too. So you might discharge a client and they're physically okay, but they may have some mental illness. And don't forget to consider it when you're caring for people. Cultural aspects are real important in mental health. You may see them doing something that you think is maybe mentally not healthy, but if you look at their culture, you understand that culturally that's something that they just do. Also, another important thing about culture is, unfortunately, we still tend to label mental illness in the country. And so, as nurses, you want to make sure that right now we start talking about it in the correct fashion. So, if you're talking about me, and I'm going to be admitted to your unit, and bless you, and I have a really bad anxiety disorder and some depression, and so I've been drinking too much and I'm just a mess, I'm on a hold, and you're admitting me to the unit, you want to make sure you don't say, oh, we're getting that alcoholic that we're putting in room 10. Or where we're putting the bipolar. Or where we're putting the suicide. If I had a nickel for every time I heard that, where are we putting that suicide? Oh, you mean the patient, Miss Johnson, who had a suicide attempt yesterday? We're putting her in room 4. Don't do that with any patient. We just joke on OD. You better get used to calling them by their name and checking the badge, because in labor and delivery, if they say, we're going to do a C-section on room 6, and you go in, hey, I'm Leslie, I hear we're going to do a C-section. We're going to go ahead and prep you. Almost any patient in that unit will go, good. And you'll prep them. You could do the wrong C-section. Because you could go up to anybody in labor and say, hey, the doctor's going to do a C-section. We're going to go ahead and prep you. And they'll be like, oh, thank God. And then you roll them out and you're like, oh, we did room 5. So, see what I'm saying? So with culture, don't label your mental health patients. You want to say, we have a client that's been diagnosed with this and we're going to be taking care of them. Also remember with culture, usually by the time a psychiatrist sees a patient with some sort of major mental illness, that's when the family can no longer deny that there's a problem. A lot of times the client and the family have been trying to deal with it, a lot of times, especially with schizophrenia, and we'll talk about it more. Once they have that big break with schizophrenia, when you start talking to the family, they're going to be like, well, you know, a couple of years ago we knew something changed. And ever since something happened, we've seen some stuff. So understand that sometimes by the time you see them at the office or in the hospital, it's been going on for a while. But nobody's been able to either put a finger on it or be willing to face it. There's just a lot of cultural things on these next 2 slides. I'm really not gonna get into it a lot. Just in your book, it touches on it. But again, I'm not gonna get into it a lot. It's a lot of the same factors that we go over in other things in mental health. You know, certain religious beliefs and all can affect how people behave, and you just always want to make sure that you understand, you've assessed their cultural and religious beliefs, and you understand they may have some, and you're not mistaking them for something different than what you're used to seeing. Real important here. Frequency, duration, and intensity. All of us have anxiety. All of us get depressed or down in the dumps a little. All of us feel a little neurotic every now and then. You got a lot going on. You got to drop your 3 kids off. You got to run by and get something done. Then you got to come to school. Then you got to study this. And you get down the road and go, did I turn off the oven? Did I turn off the oven? Can't remember. And you have to turn around and go check to see if you turn off the oven. That's a little bit neurotic. All of us end up with a pulse rate really high and our palms kind of sweaty before we take an exam. That's anxiety, okay? But what separates us from having those periodically experiencing those type of things is the frequency. All right, am I having to go back home and check my oven every day? Or did I just have to do it a couple times when I was really, had a lot going on? Or am I doing it 5 times a day? Or is it to the point where I can't leave my house? Duration. All right, so I was anxious before the test. My pulse rate was up. My palms were sweaty, and I was a wreck. Am I that way 2 days later? And nothing's going on. Duration. And intensity. Am I depressed because my cat passed away? My cat did pass away every weekend. And, I'm just sad. That was my cat. I like my cat. When I think about it, I might get a little tearful, and then I move on. Or have I had to call into work? It's been a month now. I'm so depressed, I don't even see any reason for going on. That's a difference in intensity. And it is this frequency, duration, intensity that will separate this normal things that we all kind of experience, most things, into, is it a mental illness, a mental problem? And when we're doing things like our mental status exam, and when you're assessing a client, those are the type of things you're looking for. Well, how long have you felt that way? Well, how worse is it now than when it was? Does it happen every day? Does it happen, see what I'm saying? This is how you assess it. And I won't go through these slides because it's kind of what I just talked about, but it gives you some examples of the difference between mental health and illness. Now we won't be testing you on statistics, but just to give you an idea, and these statistics are probably old because I think the depression is probably higher, but you see 20% prevalence in the general population, so 1 in 5 people have depression. Post-traumatic stress disorder, PTSD, about 8%. 1 in 10 with a panic disorder, and 2 in 10 with chemical abuse. They told us, the pharmacy board came and met with some of us nurses one day and told us 1 in 10 Americans are probably chemically dependent, but in the hospital they think it's higher. Why would all of us in the hospital have a higher rate for chemical dependency?
Stress.
Access, stress, what's some other ones? Personality type, high performers,
overabundance of type A personality.
yes.
You have to keep going and going and going.
Yeah, we're all a bunch of type A's. So the prevalence is probably higher. So will you be working next to a nurse that's stealing drugs from
Yep.
a cancer patient?
Oh, yeah.
Will you be working next to the nurse that's stealing drugs?
Mm-hmm.
Yeah, you will. If you do it long enough, you will. So just, that's one reason why understanding prevalence is important, because just don't think once you step in the hospital you're in with a bunch of squeaky clean people that would never do something or need some help. That's the biggest issue. You're in there with people that, even though we're the helpers, a lot of people, you still need some help. And we'll talk about that more in the chemical dependent part. So when you're assessing these patients, you don't want to forget to do the physical assessment and the past medical history. There's There's a lot of things that could be going on medically that could be construed as depression, as a mental illness. They could have a thyroid issue going on and it's coming across as depressed, okay? Client identifying data, what are they saying? What's their past psychiatric history? Any history of substance abuse? Current problems? What's going on with you now? So tell me what's going on with you now. What's causing you stress? What's changed? Are you going to ask them, are you having any stress? That's a yes, no question, and that kind of goes without it. Question, we all have stress. Family and cultural data. So who do you live with? So what's your support system? Who's your family? Are there certain cultural beliefs that you believe in that are real important to you? You need to know. And then you're going to do that mental status exam that we will do in the lab together. Diagnosis. DSM-5. The DSM-5. This is the book that lists all the mental health diagnoses. But I'm a nurse, I don't deal in medical diagnoses. Well, you need to know what the diagnosis is because you need to know how to take care of them. So this is where after you and the nurse prac or whomever is doing all your assessment and the provider is going to look in there to diagnose this person, that's where the diagnosis comes from, DSM-5. And it's a standardized language. It lists the defining characteristics and symptoms for each disorder. So if you look up like chronic anxiety disorder, it lists the symptoms and all there. So what does that do? That makes sure that there's a consistency in labeling somebody with a diagnosis, okay? And consistency in it. If I went to a doctor in California or I went to a doctor in Vermont or Mississippi, this DSM-5 is the go-to for everybody, okay? And it can assist in identifying underlying causes. And that's important to us as nurses because it might help us understand that diagnosis and kind of understand where this client's coming from. So we do need to know it. Now, nursing is NANDA. So in NANDA, some of the main ones we'll be using in mental health are ineffective coping, anxiety. You can be using some of those that we might not use as much in med-surg. Again, goals of psychiatric care, you want to decrease their anxiety, increase their reality testing, and that is their ability to understand what is really going on, whatever that may be. And depending on what's going on with the patient, that could be harder and harder and harder. Increase their self-esteem and increase their level of functioning. So no matter what my patient is or has going on, am I going to be able to go in and tell them, you're a great person, you just have faith, you're better than you ever thought, we're going to work on your self-esteem today, if their anxiety level is through the roof? No. You got to work on, like we said, Maslow's hierarchy, the sleep, the anxiety, and then we work on these overarching goals. Patient rights. They get admitted to mental health on a court commit, and they don't have any rights. Is that right? Mm-hmm. No, instinctively you know that's not right. I'm admitted. I tried to commit suicide. My husband and I had been fighting. I'd been drinking, and I tried to commit suicide. So I got admitted, and I'm on this 72-hour hold. Can that doctor just come in and take me and do electroshock therapy without informed consent?
No.
But I'm a court committed. So I was trying to kill myself. Right.
They still have the right to refuse.
Yes. Patients that have a mental illness have a right to dignity. They have a right to receive treatment. They have a right to refuse treatment up until the point where they are not a threat to themselves. Okay? And then at that point, you would need to appoint the court. Okay. Yeah. And even if I can't take care of myself, I still have somebody appointed that is my person, making sure that I have a right to treatment or a right to refusal. Okay? So we'll get into it a little bit more in depth. They have a right to informed consent. Working in OB. Got the patient that came in from Cersei. Schizophrenic. Thought the fetal monitor was injecting alien babies into her. Can we take her in the back and just do a tubal? She still has a right to informed consent, and she has a right. Do we maybe want to look at going through the court system and appointing somebody and maybe getting a court order?
Guardian ad
litem or something? Yes, we do, but we do just not knee-jerk take away their rights. And even if they can't express their own right to informed consent, someone who's representing them can. Okay? They have a right to communication and confidentiality. They have a right to care and custody of their personal effects. I come into the mental health unit, and you're going to take out my shoelaces. You will. Take my shoelaces off. When I get ready to go home, do I get them back? Yeah. I want to leave against medical advice. I've been here 3 days. The doctor feels like I could probably go home tomorrow. And I'm ready to leave tonight, but he's not here. And I'm ready to go home. I'm not suicidal. I didn't come in for that. And you as the nurse step in and say, well, I'm not giving you the food. Not today, please. Can you do that? And we'll get into that more in a little bit later. But you can't just withhold my stuff. They still have a right to vote, and they still have rights and phone numbers and right to access of care. Now, they have a right to privacy in the hospital, but what most hospitals will do is, when you get admitted, bless you. Well, my daughter is my caretaker, and I don't mind what you tell my daughter. She's going to be helping me when I go home. She's going to come to some therapy sessions and all. Well, and I don't mind if you give her information. So what you will do is give that daughter a code number or a word, and you put it in the chart. So if my daughter Beth called up and said, hey, it's Beth, I'm Miss Lyons' daughter, I was calling to see how she was doing. The nurse would say, oh, okay, well, this is Leslie, I'm her nurse. Do you know that passcode for Miss Lyons? And she would say whatever it was, and then I would be able to tell her, well, she's doing really good today. She slept all night, so they can't, that does happen because family members are real important, and getting them through the admission and all, but you can't just give out information unless there's a process for releasing that private information. Okay, so due process and civil commitment. And I'm asking you here now, if you work in a hospital, or if you work in long-term care, and you saw things that might not happen this way, just kind of put it out of your mind. And if you had the case that was so complicated that it took too much for the court to work out, don't go there with this, all right? We're wanting you to just learn the basics for a safe and effective entry-level RN, okay? You don't need the RN that's been working in the mental health unit for 3 years and is getting involved in some complicated case, okay? Because I'll tell you, it can be complicated. How do mental health patients come into the hospital? And if you look in your book, this is all in chapter 6. Chapter 6. On page 93. You can have a voluntary admission to the hospital or an involuntary admission to the hospital. I can come in and say, I need to be admitted and be a mess, and I can get admitted. Or the family can put out a court commit on me, and the police can come pick me up and bring me in for an evaluation. The ER doctor can see me and say, yep, she needs to be in for a 72-hour hold, or it could be brought in for other reasons. Usually, the involuntary, there's somebody there appointed that can evaluate you and say, yes, this person needs to be held for 48 to 72 hours. It's observation, It's usually short-term, or it could turn into a long-term thing. I get brought in, the doctor says, yeah, I need to stay 72 hours. Somewhere in there, they decide she does not need to go home, and I may get transferred to somewhere like Searcy or Whitfield for a longer term. Then, well, how do you get out of the hospital? You could be discharged on a conditional discharge. Well, we're going to let you go home, but part of what you have to do, court-ordered AA meetings or court-ordered daily therapy. There just may be some sort of stipulation on it. Way different than if I just got discharged after having my appendectomy. Okay, there could be some conditions, or I could just be straight up discharged. You did great. You've been here with us for 7 days. We're going to let you go home. And again, they maintain the right to treatment. I come in, I am violent, schizophrenic, out of touch with reality. I beat up 3 security guards. I bit a nurse. Can we just not treat them? Let's just not treat them. I don't want to do that. I have a right to treatment. I have a right to refuse treatment. I don't want that electroshock therapy. And until they can prove through some court order that I'm really going to hurt myself, I can refuse that. And I have the right to informed consent. You just can't come in and do something willy-nilly to me without having to do informed consent. And again, all spelled out, nice and neat in your textbook. And it also lays out when you can trump those rights, okay? They have to be like to the point of hurting themselves or hurting others. And then you can step in and say, we're going to have to give this medicine. If we waited for every patient to consent to restraints, you'd never put anybody in restraints, okay? So why do you put restraints on somebody? Because they're going to hurt themselves or somebody else. Do you go, so that's your best understanding of how this works, okay? Yeah, we want them to consent. Yeah, we want them to be able to refuse treatment. And yes, we want to take care of them. But sometimes they may be so violent or so unable to help themselves that we have to either an emergency situation, which is what restraints are, step in and restrain, or we have to go through the court system to get somebody else to speak for them. Okay. And the book, I like the book on this section. When you get home and you're going over it tonight, lays it out clearly. And on page 95, right there at the bottom, it talks about in an emergency to prevent a person from causing serious or imminent harm to others, you can medicate a person without a court hearing. Okay. You got somebody that's, you're needing to give some chemical restraints to in the form of a big dose of Haldol or something. You're not going to call your hospital attorney and see if you can get in court tomorrow and get a court order. You're going to have to go with that provider's order and go ahead and do something to keep this person from hurting themselves. But now, if you think they need electroshock therapy and you got some time, then you can go through the court system if they're going to refuse it and try it. So, those are really sometimes gray areas, but they're real clear when you understand this. Voluntary versus involuntary broken down on one slide. A voluntary admission versus an involuntary admission. You go in voluntarily and you're in control of yourself and you're able to make the correct decisions and not hurt yourself. You maintain all your rights. You come in involuntarily and it's seen that you're a risk for hurting yourself or others. You may not retain all of those rights, but you will have a court order and someone there to make the decisions for you. It doesn't just go away. And here's those criteria for an involuntary admission. Dangerous to self or others, mentally ill and needs treatment and unable to provide basic needs. Okay, so now we're going to talk about what we as nurses, what we don't want to happen with these clients. We're going to talk about intentional tort. So we're talking about the law. And if you look in your book, this is still in chapter 6. And it starts at the bottom of page 99 in the book. Little good paragraphs that break all of this down. And willful or intentional acts that violate another person's rights or property. So if I'm an RN and I assaulted somebody, do I have other things to worry about other than malpractice?
Mm-hmm.
I can have criminal charges. Have nurses ever been charged with murder when they were restraining somebody?
Yeah.
Yes, they have. But that's if you intentionally do something. Okay. Now, I accidentally I did something and I caused injury, and generally nurses are charged with some sort of a civil suit. Okay, so what do you have to prove to show that I was negligent and did some of these torts? Well, you have to show that I was legally responsible for providing care to that patient. I was a nurse on that unit, and that patient was assigned to me. Yeah, I had a legal responsibility. I was driving down the highway and I drove past a wreck. You have to show that I performed it negligently. I breached my duty. Okay, so I was taking care of this patient and I lied. I really didn't go in and check them every 15 minutes like I was supposed to. I thought they were asleep. I didn't go in for a while. So those vital signs and stuff that I charted, I made them up. I kind of copied what the years before me wrote. I was negligent. Well, the next thing you have to prove is, did that negligence cause this injury? Well, yeah, you were supposed to be checking them every 15 minutes. And in a mental health unit, you have to lay eyes on every client every 15 minutes, in general, unless they're a 24-hour observation. In general, you have to see them. Somebody has to lay eyes on them. Well, yeah, this patient hung themselves. And the best we can tell, they hung themselves somewhere around 10 p.m. And you were not charting and not observing, so that probably was negligent. That was the cause in fact. Because sometimes you just could do something negligently, but it didn't actually cause the injury. And then was it legally the cause? Did we show that me not checking on that patient is what happened? And then were there damages? That's the things that they're going to be looking at with us. So what are they? False imprisonment. Remember when we talked about, well, I want to go home AMA, but you're just going to keep my car keys and not let me leave? That could be considered false imprisonment. I can't, and that can happen on med surg floor. I can't just force somebody to stay. You know, they have rights and all. So false imprisonment. Assault and battery. These are on page 100. What's the difference between assault and battery? Assault is threat and battery is the actual harmful or offensive touching of another person. I'm in your 11 inches. I hate that. And touching people. Ms. Johnson, don't leave. You don't need to leave the unit now. You gotta watch touching people when you're telling them they can't do something. Is touch important? Yeah, and in mental health it's real important. You know, how are you doing? You look different today. Do you want to talk? As opposed to, oh, you can't go.
Yes, I can.
No, you're not leaving this room. What am I doing? Yeah, stop! Don't do that. So these are all on page 100, spelled out nicely for you. And then violence. Protect yourself and use common sense. You're trying to hit me. I'm trying to get out the door. I might touch you at that point. Whoa, I'm trying to protect myself and get out the door. I may have to touch you to put you in 4-point restraints. But I'm following my policy, I'm doing my guidelines, I'm making sure I'm following the guidelines and doing what I'm supposed to do. Security support. 9 times out of 10, when you hear a code gray in the hospital, where is it being called to? ER or mental health unit. Always have your security support there with you if a client is, if you think you're going to need help, so that you're not having to do something like push them off of you or do something, bring in the security. Sometimes just the presence of security and the presence of a little bit of authority helps bring people down a notch. Employers are not typically held responsible for employee injuries. Sometimes you get hit. I've been kicked and hit, thrown up on, beat on. You generally, that's just kind of part of the job, and the employer is not held responsible. Like I couldn't go to my employer and say that patient bit me and sign him a suit, unless you can show that the employer is negligent, and that's just a rabbit hole. Nonviolent crisis intervention. What you often see is in the hospital, you have a group of individuals that are trained in how to de-escalate. Nonviolent crisis intervention. That patient's pacing the floor, they're really aggravated, they're getting cranked up, you know that something's going to happen. You've got your mental health nurses, a lot of times your ER nurses, your nursing supervisors, your providers are trained in special skills in how to approach that person, not front on, all these tips about a side approach, some things you can say, and they're trained in how to avoid having it escalate, spiral out of control. Negligence is when you do something negligently to a patient. I put restraints on that. I did something that caused damage, or it could be I omitted something, like checking the client that I talked on earlier. I omitted all those assessments that I should have been doing. That can be considered negligent, and I breached my duty, and it has to result in somebody's injuries. Can I be negligent and they not have an injury?
Yeah.
Yeah. But when we're talking about a suit, a lawsuit, and then proving that I was negligent, you have to link that with it's usually linked to some kind of injury. You can be negligent all day long and maybe get a wrong, but as far as with the lawsuit, you have to show that the negligence caused it. Then you got the duty to intervene and the duty to report. Y'all know we're mandatory reporters. And one thing with mental health is I'm the nurse on the floor and the police come in. Hey, look, we're investigating this murder. We want to talk to you about Miss Smith. Tell me what you know. Can I tell them stuff?
No.
Please.
No.
And they're investigating a murder.
No, without a warrant.
Okay. I'd love to talk to you, but I'm going to talk to my charge nurse, and they can't just come get you that private information without court. Ms. Lyons? Yeah. This is Ms. Johnson from the insurance company. We wondered what was going on with Ms. Smith. Without needing to give case management information or billing information, can I just give information to that insurance company?
Mm-mm.
Now, if I'm the case manager trying to work the bill out in their state, that's different. Well, now I have this patient, the one the cops asked me about, and they tell me, if y'all hadn't put me in tonight, I would have killed Joe Schmidt. And I've got a gun in my truck, and when y'all get me out of here, I'm going to kill him. Then I have what? I have a duty to warn. That's when a nurse can say, whoop, charge nurse. And then that's when the charge nurse follows the proper chain of command through the supervisor and probably through your hospital attorney. Then you have a duty to warn a third person. You had something specific threat that you need to pass along. Okay? So, and that's also in your textbook in the same chapter. And I'm going to go over a little bit more and we'll take a quick break. Is it lunch at 11? We'll do lunch. We'll do lunch, and since it's about 5 after, y'all come back at 5 after 12. We will pick